information, please refer to the description box below, and we do appreciate your feedback. So don't hesitate to share your thoughts or questions in the comment section for further clarification on any topics discussed. Now, we want you to join with the Stancoast NCLEX coaching for the comprehensive NCLEX prep. And hopefully that you're going to enjoy the clear lectures and a massive question bank with over 3,000 NCLEX style questions. And this is really going to give you a quick review with our audiobook and also the bullet book. And you will benefit from 100 hours of preparation and also 10 hours of animated video series. Now let me just check something real quick here. Now, you also will have access on the on-demand video library and also the practice and MAC exams. And also you will have the access for about 6 months of all the 200 plus NGN test questions. And you can do this anytime, anywhere, and make this your ultimate NCLEX preparation solution. So today we'll be talking about the pneumothorax and hemothorax along with the chest tube management. And this is one of the frequently asked questions in the NCLEX. Now, before we get to the meat of the topic here, we really want to define first what a hemo or pneumothorax is. So you'll see here our different definitions of each problem. And so the pneumothorax basically is going to involve with the presence of air, or let's say accumulation of air in the pleural cavity, and this is going to cause the lung to collapse. So it can be unilateral or it could be bilateral, but most often it will be unilateral. Now there's also that term we call as tension pneumothorax. So what is that tension pneumothorax? This is basically going to happen when the air enters the pleural space during the inhalation through a one-way valve, and they cannot exit during the exhalation. Now, what's going to happen here is that the trapped air can increase the pressure on the heart and the lungs. So pay attention here. The tension pneumothorax can compress the blood vessels and also will reduce the blood venous return into the heart, and this can lead into a decrease in the cardiac output. Now, what I just said here regarding tension pneumothorax, it can cause problems into the heart and the lung function because, again, it can compress the blood vessels and it can reduce the venous blood return into the heart, and subsequently it can also decrease the cardiac output. So with that, you're not really going to expect perfusion into the major organs in the body when the cardiac output drops, or let's say the blood pressure drops, because that's pretty much like synonymous, right? When the cardiac output decreases, the blood pressure will also decrease. So you're not going to expect a whole lot of oxygenation to the body tissues, and so the body will respond by being restless, confusion, agitation, and so forth, with tachypnea and so many others. Now, without immediate treatment with these two, pneumothorax or tension pneumothorax, these can be fatal. Now, with the rising air and also pressure in the pleural cavity, it can also cause a shift on the mediastinum. So take a look right here. And the mediastinum right here, look into the movement wherein there is that lung collapse on the right side. The right lung is actually collapsing, and now with that presence of air occupying that pleural space, it will push to the opposite side, and along with the heart, also the trachea. So look at that, it will compress both the heart and also the lungs. And again, we're talking about the cardiac output here, the venous blood return, and these will be compromised. All right. Now, talking about another thing here, we have spontaneous pneumothorax. What is this? This is something that can spontaneously occur without trauma. So this is the key word here. Spontaneous pneumothorax can happen without trauma. However, though, this can involve the rupture of what we call as a bleb, or let's say in some emphysematous type of like sac. And so when that ruptures, this will now cause the air to go into the pleural space and will do the same thing. It will lead to lung collapse and also some mediastinal shift. Now, lastly, what we have here is the hemothorax, which is basically a collection of blood into the pleural cavity, and this is associated with trauma, maybe blunt trauma, or could be sharp objects that has penetrated the chest wall, maybe due to vehicular accident, or could be a stab wound. All right. Now, let's move forward here with our discussion regarding the different risk factors. Like I have said earlier, the hydro or the pneumothorax rather, or the hemothorax, these are going to be caused by so many factors, and one of these is the blunt trauma to the chest. And this can cause the lung tissue to rupture, or maybe it will cause the pleura to tear, and this will not allow the air to leak into the pleural space. Supposedly, it should not allow that in a normally functioning lung, okay? Because if there is too much air, if there is now accumulation of air in the pleural space, again, it can now compress the lung tissue. It can also lead to lung collapse. Now, another risk factor here is the penetrating chest injuries. What is this? Well, of course, like I've said, it would be related to stab wounds or maybe gunshot wounds that can puncture the lung or the pleura, and this can lead to air entering into the pleural cavity, and it can cause pneumothorax. Now, there's also blocked or closed chest tube. So guys, even when your patient has, let's say, the chest tube for some other reasons, maybe to drain some accumulation of like pus, with the presence of the chest tube itself, even though it's used for treatment, it can become blocked or it can be closed off, and this will allow the air to accumulate, leading to a pneumothorax. So that's why you really need to pay attention to those patients with the chest tube. Now, for those patients like the elderly group, they have reduced lung reserve due to the normal aging changes, such as decreased elasticity and also thicker alveoli. And the aging process can also reduce the elasticity itself. And so this is going to make the lungs more susceptible to collapsing and also less able to recover from any injuries or maybe other conditions that could potentially cause pneumothorax. And then we also have the COPD itself. So please pay attention here, because the COPD can also do that. And so in itself, it can damage the lungs, and it can lead to the formation of the blebs, like small air-filled sacs that can actually rupture, and they will allow the entrance of air into the pleural space, and it will cause the pneumothorax as well. All right. Well, I hope that you're able to capture those, and we're actually glad that you're here with us today. So yeah, just enjoy, sit back, and throw in your questions as we go along. Now, we were going to talk about the different complications of either hemo or pneumothorax. Well, again, like I've said earlier, it can compress the blood vessels, right? And it can also decrease the blood return to the heart. And so one of the complications here is the decreased cardiac output. That's the first one. All right. And so what's going to happen here? Well, the heart, the cardiac output per minute, of course, will be decreased as the intrathoracic pressure increases. Again, the compression in itself can actually cause issues with how the heart will be able to do its activity, like the pumping mechanism. Now, when this happens, when there is decreased cardiac output, it can also lead to low blood pressure. Okay? Again, The low cardiac output can lead to low blood pressure. Now, another complication here is the respiratory failure. Well, that's because of that inadequate gas exchange due to the lung collapse. All right, did you ever see that picture that I showed you earlier regarding that compression? Let's go back to that right here. You will not expect good air exchange here when that lung tissue, the three lobes of the right lung, is collapsing. No, your perfusion and also the ventilation is actually affected this time. So this is a life-threatening condition that needs to be addressed immediately. All right. Now let's move on into the different testing that we can anticipate or being ordered by the medical provider. And so one of those laboratory tests is the arterial blood gas, of course. And this is going to give us an idea about how low the oxygen is going to be. And also there will be a drop in the oxygen concentration, maybe less than 80 mmHg. All right. So that is an expected assessment finding in our patient. So again, the arterial blood gas will reveal that there will be a decrease in the oxygen level. Now, another testing that would help really, I mean, it's not really a diagnostic test, but it will help, especially in a case of hemothorax or stab wound type. Well, we're going to need some information regarding the CBC, right, to check for the hemoglobin levels or the red blood cell count. Or if this is something that is associated with, let's say, empyema or hydrothorax, we're also going to look into the white blood cells count as well. All right, so to see for any kind of infection. Now, other diagnostic tests here will also include the chest x-ray. That will confirm the pneumothorax or the pneumothorax. Again, the chest x-ray can help us out. Now, another diagnostic test is the thoracentesis, which is going to be used to confirm hemothorax. All right, remember about that procedure. This is invasive, and this is now the surgical perforation of the chest wall. And again, this is directed into the pleural space with the large bore needle, and this is going to allow the drainage of the fluid, or let's say the blood, in order to decrease the pressure inside the pleural space. Now, I think I've discussed this way back in our previous lecture regarding diagnostic tests. And so again, this procedure will really require you to keep an eye onto the preparation. Make sure that you have obtained the consent of the patient. Make sure that you're going to assist with the positioning during the procedure. Make sure that the patient understand what's going to be involved during the procedure as far as their activity, that they should be sitting still. They're going to be needing some vital signs monitoring around this time. And also take a look into the injection site. All right. Now, we're also going to help the patient to sit at the edge of the bed or maybe to lean over a table in order to stabilize them while the procedure is going to be conducted. Now, one of the education that we're going to offer to the patient is to give them that info regarding no coughing at all, no deep breathing, and no moving. Okay, so this is very important. Let them know to avoid these things. The deep breathing is even not a good idea. So you're also going to have to inform the patient of the discomfort that they're going to feel during the procedure. Of course, they're going to feel some pain, but a pre-medication would also be involved. An anesthetic agent will be given in order to numb the area. And also they can feel slightly that introduction of the needle that will be directed into the pleural space, and they can feel that pressure, but there will be no pain at all. All right. So make sure that they are given concise explanation and making sure that they know what to expect so they don't get surprised at all. All right. Now, at this point, we're going to talk about the general nursing care. And this is geared towards the acute phase wherein the hemothorax, or let's say the pneumothorax, has occurred. So I'm not talking about anything else, just during the acute phase. So at this point, when you have assessed your patient that you're suspecting probably that your patient is having a pneumothorax or hydrothorax or hemothorax, then one of your interventions here is to administer the oxygen. Okay. Well, of course, you're going to see that their oxygen saturation is dropping, probably less than 90% or kind of around 92% in room air. And you probably have noticed that there is a change in their respiratory rate. It's getting higher and higher. And also probably you're noticing that there is some asymmetrical movement of the chest wall. That's not good, right? Around this time, you really need to auscultate the patient's heart and lung sounds and also check the vital signs, minimum of at least every 4 hours. But during the acute phase, your vital signs monitoring will probably be as frequent as maybe every 15 or 30 minutes. So you expect that this will be much more regular and frequent. Now, we're also going to document if in case that the patient will require the ventilator or let's say intubation because the patient probably went into respiratory arrest. Well, that would really require you to make sure that you document the ventilator settings hourly, also to check for the symmetry of their chest wall. I mean the movement of the chest wall, and also making sure that your patient lab results, let's say the ABGs, oxygen saturations, complete blood count, and also the chest x-rays have been evaluated in a timely manner so we can address those issues. And you can also assist the patient in positioning, of course. And it is recommended that they're going to be sitting upright, 90 degrees angle, in order to facilitate maximum lung expansion, and also possibly administering intravenous fluid, or could be blood products if in case there is hypotension because of the low cardiac output. And we also probably need to replenish the red blood cells that have been lost in the bleed in a case of hemothorax. And part of the care here will is to give emotional support to the patient and their family, and to prepare them for mechanical ventilation as well. We got to check for the intake and their urinary output as well. And also checking for or preparing them for mechanical ventilation if there is an impending intubation, right? Now, also at this point, we're going to have to continuously check the respiratory status of the patient, as we know that this is the most critical phase. There will be a whole lot of changes when there is that mediastinal shift with a compression of the blood vessels. And it will also involve monitoring the chest drainage as well, the chest tube, to see if there is excessive bleeding, or let's say if there is an abrupt stop in the drainage. That could mean maybe there is a fibrin clot that is occluding the drainage, and this is gonna need us to really pay attention to that and make sure that we are reporting that immediately to the medical provider. And also to administer prescribed medications, could be sedatives or benzodiazepines, or could be opiates, in order to help our patient relax or to control their pain as well. Now, we're going to talk about the different pharmacologic management, and we'll just kind of touch it really very in a superficial level, because this is not really our main topic, but just to give you an overview of what possible medications that we can administer during the acute phase. Well, of course, here you go. We got the benzodiazepines, and most of these, or two examples of the benzos that we're going to expect to be ordered, is the midazolam or the lorazepam. And this is going to be ordered and given to reduce the anxiety of our patient. And we're also going to monitor the vital signs when we are giving our patient the benzos, because this can definitely cause a reduction in the blood pressure. And another thing is that it can lead to respiratory depression. So you got to be really cautious before you administer this medication, because again, it can probably cause so much complications. All right. Now, also be aware that this can also lead to amnesia, and also it can cause some euphoria, which is a paradoxical effect to the patient, or maybe they probably will change their behavior. There will be some rage instead that they're going to be sedate. So that is something that probably would surprise you. Now, another group of medications that we're going to talk about are the opioid analgesics. And this is represented by the morphine sulfate or fentanyl, or it could be the dilaudid or hydromorphone. And so these medications are going to treat the moderate, or it could be severe form. And this is going to target the kappa receptors, which will help relieve the severe pain. Now, again, guys, when you're going to think about the opioid analgesic, we have a question here from Jocelyn Diaz. Can tension pneumothorax put pressure in the heart? Yes, I've mentioned that earlier on. Like I've said, it can compress the blood vessels. It can also reduce the blood return to the heart. And again, it can reduce the cardiac output and subsequent drop in the blood pressure. All right. Now, with the opioid analgesics, I really want you to pay attention here regarding the opioid analgesics. This is going to really control their pain, right? Like I've said. But again, this is going to be causing side effects. It can lead to respiratory depression. And so with euphoria, it could cause sedation to the patient and also a reduction in their GI motility. So think about those possible side effects here. Now, with that, we are going to have to assess the patient, monitor for their pain level, maybe more frequent than every 4 hours, especially during the acute phase. And you got to be cautious here, especially, yes, you got to be cautious, especially for those patients that may have a pre-existing condition, maybe an asthma, or could be emphysema. These are those people that are at risk to developing the respiratory depression. All right. And so when you're going to notice, let's say if your patient's respiratory rate drops, let's say into 12 cycles per minute, or let's say less than that, well, that's not good. When your patient becomes bradypneic, yeah, your patient will end up with some respiratory acidosis. And we don't want that. And also, if the patient's respirations will be as low as, let's say, 10, 8, or 6, that needs to be reversed. And do you recall that we're going to need to reverse that with that antidote Narcan, right? Or the naloxone. Remember about that medication? Let me change my pen here. So when you are seeing the patient's respirations getting a lot lower this time, you really need to pay attention to that, because with the respiratory depression comes different complication. So make sure that you're going to notify the medical provider. Where am I going to write here? Notify the provider and anticipate the administration of naloxone in order to, where's the N here? Okay. Anticipate the administration of naloxone in order to reverse the adverse effect or the effect of the opiate. Okay. We really want to address the respiratory depression. Now, aside from that one, we're going to need to monitor the patient for their low blood pressure, because it can do that. And also make sure that you are monitoring the respiration of the patient. Check for any nausea and vomiting, because this can also occur as part of the side effect. The level of sedation, And also, all throughout the therapy, when we are going to medicate the patient with opiates, always monitor the patient for the constipation. Okay, that's not good. We want to make sure that they can pass their stools daily, and also encourage them to increase their fluid intake daily in order to prevent constipation. All right. Now, part of the care here is to monitor the intake and output and also report if there is any kind of fluid retention, because retention of fluid is an adverse effect with these medications. All right. All right, so these are just generic right now. We're going to talk a little bit more of the different nursing interventions in the next few slides. I just kind of put them into different chunks so at least you will know what to do with this kind of issue. I don't really like to put them in a cluster like general because it gets too confusing. So I want to make sure that you know what to do at this instance. All right, so that would be my kind of approach when I'm dealing with the patient when they're manifesting different signs and symptoms. Now, what we're going to do at this time, we're going to expect that the medical provider will plan on immediately insert the chest tube. Okay, this can happen anywhere, guys. It could happen instantaneously when you're just starting your shift, or maybe if you're an ER nurse, you're receiving this patient with a blunt chest injury. Yeah, you got to be just be prepared because anything can happen. Now, what we're expecting again, chest tube insertion. So this is going to be placed into the pleural space, and the uses of this chest tube insertion include the reestablishment of the negative pressure. It will also drain the fluid, the air, the blood, and also it can facilitate the lung expansion. All right. Now, please take note, guys, that with a chest tube insertion, this can also restore the normal intrapleural pressure. Okay. So this is basically the, I'm talking about the stability of the pressure inside the thoracic cage. All right. Or inside the lungs. And so, or the pleural cavity, I should say. So with this, we want to make sure that this is restored, or else again, your patient will go into respiratory arrest. And so here, we want to make sure that we're going to do this procedure really quick in order to stabilize the lung function. Now here, what are we going to do during the pre-procedure phase? Well, everything's gonna happen way so fast this time. So again, we are going to confirm that there is signed consent. All right, make sure you have that. And if this is not like, let's say for example, if the patient is not really in an emergent kind of a situation, it's not like the patient is dying or something like that. Maybe there is still a good chance for you to really explain a whole lot about what this procedure can do to help their breathing and also after the procedure. So you can do that as well. Make sure that you check for the patient's allergies, maybe if they have any history to allergies to anesthetics, make sure that you have that information and assist the patient to sit upright. Supine position is the best position for this patient, or it could be a semi-Fowler's position or according to the patient's tolerance. Now, along this time, we're going to need to prepare the drainage system. Make sure that you have that drainage. Let's say the, what do you call this? The oasis, or it could be the atrium kind of equipment. I'm talking about the water seal, the chest drainage system. So make sure that you have readily available and some other equipments. Make sure that you're also administering the prescribed pain medication and sedation as ordered. And also you're going to have to assist in cleaning the insertion site using aseptic technique with the approved agent. All right. So possibly the patient might be needing the chlorhexidine, or could be betadine, povidone, iodine, or it depends on the medical provider's preference. Or if the patient may be allergic to any of those, then definitely we're not going to use those kind of substances. All right, so what are we going to do now? During the procedure, what we're going to need to do at this time is to assist with a tube insertion. Your assistance is a big deal around this time. Your coaching would really help out the patient, especially if they're so anxious. You can really help out, at least calm the patient down during this procedure. Also, during the application of the dressing, and also making sure that the setup is completed, connecting those tubing. And so what we're going to do here is to also expect where the incision site is, because it does matter here. So if the patient has a pneumothorax, well, you're going to expect that the incision site will be at least on top of the chest wall, right? Above, because air rises. However, though, if the patient has hemothorax or hydrothorax, the incision will be done at the apex, okay, or the base, in order to properly drain the fluid or the blood. Now, around this time, when the incision has been created and the catheter or the tube has been advanced into the pleural cavity, then we want to make sure that the drainage system is placed below the chest level, okay? Make sure that you do that in order to allow the drainage of the blood by gravity. So that is very important. Now, during the immediate post-procedure, your vital signs monitoring is very important to see if there is progression of the manifestations or if there is any improvement to the hemodynamics, maybe the blood pressure, the heart rate, oxygen saturation. Make sure that this is continuously monitored, so we will be able to address it real time. All right, guys. Now, during the post-procedure, what we're gonna end up doing here is gonna be the same thing. Continuously monitor the vital signs. Along with that, we're gonna have to auscultate the patient's breath sounds. All right, to see if there is some improvement, because when we have that pneumothorax, when the patient has the pneumothorax, or let's say the hemothorax, remember that there is some sort of a collapse in that lung tissue. And so what you're going to expect around that time, before the procedure was done, then there will be diminished breath sounds, right? So after the procedure has been done, then probably you're going to be hearing more breath sounds, probably more movement of gases or air. And so you're probably going to hear that more often. And so you have to update the medical provider if there is worsening in the diminished breath sounds. Now, what you're going to end up doing also is to encourage your patient to take deep breaths and also coughing at least every 2 hours in order to get rid of that pneumothorax into the drainage system, and make sure that we have the drainage system below the chest level, even when they are ambulating. So if they have to use the bathroom, make sure that the drainage system is going to be at least below the chest level, or let's say below the waist level. Now, this is very important, guys, that you have to check the chest tube placement as well. So you will need to maintain the level of the water. I'm talking about the sterile water level into the chambers here, okay? So make sure that you are checking into the also the amount of the drainage. Maybe if it's kind of bloody during the first few minutes, take a look if the bleeding is so excessive. And so if it comes to a point wherein the bleeding reaches about 200 ml, that is significant, okay? Let me write that down. So if your patient has an extensive amount of drainage, let's say, for example, 200 mLs of blood draining into the collection chamber. Why is this pen not working? Oh boy. I'm not quite sure. Okay, let me just use my mouse. So let's say, for example, if the drainage exceeds the 200 mLs less than 24 hours, all right, this is significant. That is already going to call you or cause you to call the medical provider that the drainage is way too much. That is a sign of hemorrhage. So make sure that you are going to inform the medical provider. And another thing that you need to pay attention is the maintenance about the fluid level in the suction chamber. Why? Well, because if there is, let's say, with the use of the suction, if there is a suction that is applied to the system itself, this can cause rapid evaporation of the fluid in that chamber. Okay? And this will lead to some more problems later on if we're not going to replenish the level. So we're going to talk a little bit more of that later. And with the dry suction, because there's two different setups here. It could be that the medical provider will order the wet suction, or they could order the dry suction. And I will explain much further with that later on. And so this is going to be regulated with the dial in order to maintain the amount of pressure in the suction chamber. All right, we don't want to exceed way too much suction in the system. Now we're also going to have to take a look into the titling, which is basically in the water sealed chamber. This is very important, guys. And also look for the continuous bubbling. Okay. And we are talking in the water, we are talking about the water sealed chamber. So if we're going to see the continuous bubbling in this chamber, that's not a good sign. However, if you're going to see the continuous bubbling in the suction chamber, that is okay. However, like I've said, if you see it in the water chamber, that's not a good sign. That could mean that there is an air leak. Now, we're also going to look into the tubing, check for any kinks or maybe occlusion, or let's say some loose connection that need to be fixed. All right. And we're going to observe for the patient's insertion site, look for any redness, if there is increasing pain or any signs of infection, or the presence of the subcutaneous air, the, what do you call that one? Subcutaneous emphysema. That's not good. That is a sign that there is an air leak. All right. Let me fix this thing. Why is this not writing? Okay. Subcutaneous emphysema. Hang on a sec. Why is this not allowing me to do it? Emphysema. Okay. So you will probably see this in your patient if there is an escape or leak of the air into the skin of the patient. You're going to feel that crepitus sound, kind of like vibration sound in their skin. That is a sign of an air leak. All right. So you really need to pay attention into the connection to see if the tubings are joined all together, and maybe there is some problem with the appliance itself. Maybe there is a crack of the appliance, and this is definitely going to require you to change the appliance. All right. Now we're also going to look into making sure you are securing the connections with tape, and make sure that your patient is going to sit upright, at least semi-Fowlers or high Fowlers, in order to facilitate lung expansion, and also medicate your patient for any pain in order that they can be assisted better into doing the deep breathing and coughing exercise. Guys, this is very important. If your patient now is, let's say, not going to do anything about it because it's just way too painful. I'm talking about the coughing. So if they're going to say, no, I'm not going to do it, it's too painful. So you got to be on your top game here. When you're going to deal with this patient, make sure that you're going to be administering the pain medication in order that they can also do the coughing and deep breathing. You don't want them to suffer in pain. And so this is one way to prevent possible complications as well. Now, another thing that you need to look into is confirming the placement of the tube by having that chest x-ray as a follow-up in order to see if the tube is well in place into the pleural space. All right. Now, also, you are going to be responsible that you have the equipment readily available at the patient's bedside, like hemostat, those forceps. Um, those forceps that are actually padded, not those ones that are like straight Kelly curves. No, don't want those because it can cause perforation into the tubing. So make sure that you have the padded forceps, not the ones with the bare teeth in it. Make sure that you have the sterile water at the bedside as well and occlusive dressing just in case. We need to have those equipment just in case if there is some kind of like a complication, maybe a dislodgement of the tube. Now we're going to have to also avoid any unnecessary clamping. Okay, we are not going to do that, guys, because it can lead to tension pneumothorax. Same thing with the stripping. In the past, it was common to do the stripping. Not anymore, guys, because it's known that stripping, unnecessary clamping can lead to tension pneumothorax. All right. We're going to have to notify the medical provider before doing this. And if they are going to approve, then you're going to do it. But definitely not do unnecessary stripping or unnecessary clamping of the tubing. All right. If in case, though, your patient becomes hypoxemic, a drop in their oxygen level would require you to notify the medical provider. Or let's say if there is excessive bleeding, like I've said, greater than 200 mLs, would require you to call the provider. And so that is a sign that there is bleeding inside. Maybe it would need ligation or cauterization of that active bleeder. Now this time we're going to have to talk about the system itself. And we are going to focus into the 3 system, because this is really going to be asked right into the NCLEX. Rarely that it will ask about the single or the double bottle system. I've never seen those questions coming up. And so with the chest tube drainage system, this is typically the disposable one, 3-chamber drainage system. And this is going to include, of course, the drainage section right here, and we have the collection chamber as well, or the water seal right here. And then we have the 3rd chamber, which is the suction. And this section right here, it could vary. Like I've said earlier, the doctor might prescribe either the wet type or the dry type. So again, the product will vary here, guys, but this one is actually the wet type of the suction chamber. So again, let's focus into the chambers here. For the first chamber, this is going to collect the drainage, whereas the second chamber will maintain the water seal, and the third chamber will control the suction. And again, this is going to be a varied. It could be the water or the wet, or it could be the dry. Now, talking about the water seal system here, let's focus on this one because this is where things gets confusing. All right. So with the water seal chamber, what we're going to expect here is that we are going to place the sterile water. We're going to add it to the chamber and make sure that we are going to instill up until we get to that 2 centimeter mark. Okay. So this is for the water seal chamber. All right. So please take note of that. 2 centimeter. That is our mark. Don't forget. Water seal. So what is the function really of the water seal? This is going to allow the air to escape into from the pleural space. So when the patient breathes in and out, The water seal will allow the air to escape from the intrapleural space, and it will also prevent the atmospheric air from entering into the chest. Okay? It will prevent the atmospheric air to get inside the patient's pleura. All right? That's the mechanism about the water seal. Now, what are we going to do here? It definitely needs to be the position of the chamber. I mean, the entire container itself, it should be placed in an upright position. We don't want it tilting. Make sure that it is placed in a flat surface. Make sure that it is well supported so it doesn't drop or it doesn't tilt to one side. Okay? We want to make sure that the water seal is kept at 2 centimeters. Okay? Now, with that, there's probably going to be a need for a suction. This is going to be a little bit more complex this time, guys. So I want you to pay attention here, because sometimes the medical provider will order suction. Okay? So let's say, for example, if the patient may have a hemothorax or maybe a large pneumothorax, probably going to order more suction for this patient. But again, it will depend from one case to the next. So this is going to be dependent. If the doctor would really want to apply suction to this patient's drainage system, again, it will vary. So let's say, for example, if the doctor will order the suction in a case of, let's say, a wet suction setup, okay, what are we going to do here? Or what are we going to expect? So I'm just going to show you first what that means. So here is our atrium equipment. Basically, our patient is going to be connected. Of course, we have the, let me enlarge this so you can see this better. So you have here the drainage system, which is basically going to catch all the fluid or the hemothorax draining into the first chamber. And so with this setup, this is actually going to be connected to the suction, which is basically right here in this, the left side of the container here. Okay. So this is what we have as the wet suction. Now, when we have that one, if there is that order to maintain the suction, we're going to make sure that the suction chamber will be instilled with that sterile water at least negative 20 centimeters. Okay, so that is our desired level, guys. Okay, make sure that you have that negative 20 centimeter level. And again, this is going to be sterile water, not normal saline. Well, why not normal saline? Because it can crystallize. All right. Now, what are you going to expect here in the wet suction? You will see some gentle bubbling. Okay, and this is expected. Nothing to worry about. We're talking about the suction chamber. Okay, so if the patient is connected to the suction, well, of course, you will expect that there will be bubbling. There will be continuous bubbling. That is normal. All right. If there is low water in the suction, maybe less than the 20, maybe there's only 5 centimeter water, maybe 10, then it will create lesser suction. So it will not do its job. So again, you really need to pay attention. Make sure that you will keep checking into the water level at least every 1 to 2 hours. Because again, with the amount of suction that the doctor has ordered, it can possibly dry up the chamber rapidly. So again, make sure you do this every 1 to 2 hours to make sure that we have the correct water level. Okay. Now moving on here with the suction, or I'm talking about the suction chamber. For example, if the doctor now orders a dry suction, what are you going to expect? So this is a different setup now. This is the dry setup. So if they're going to prescribe this one, again, what we're going to need to do is to make sure that we set up the suction level. And often it's going to be the same negative 20 cm of water. However, though, this is going to be adjusted with this mechanical regulator right here. Let me change my pointer. So this is going to be where when you're gonna regulate the amount of suction. All right, let me enlarge that one. So there's that -20, -30, -40, -10. So this is actually a much better product that can safely regulate the amount of suction for this patient. Okay, let me exit here. So that's the role of the mechanical regulator, to maintain that appropriate suction and make sure that that we are looking into the correct container, guys. Okay, make sure that you're familiar if this is a water or is a wet type of a container, or if this is a dry, because they totally look different. Now, what's the benefit of using the dry suction type? Well, it doesn't require water, and it doesn't really require you to keep checking every 1 to 2 hours just to look into the water level. And what you're gonna do here instead is to regularly check the mechanical regulator. And again, it will be according to what has been ordered by the medical provider. It could range somewhere between -10 to -40. But again, most often it will be -20. Generally. cm water. That's the usual order. Now, with a dry suction, this is going to be more consistent and more fluctuation as far as like the water level in the suction chamber. So again, this is a much safer way of managing the patient's chest tube. Now, this time we're going to talk about the titling. All right, so this is another what I call observation that you need to pay attention in this patient. So what is the titling? This is going to be observed again in the water seal chamber. We're not gonna look into the water in the drainage chamber, or let's say the suction chamber, but we will focus into the water seal. So what is this titling? Well, basically, this is the fluctuation of the water. Okay, when the patient breathes in, let's say, for example, when the patient has spontaneous breathing. So right here, this is what I'm talking about. We are on the water seal chamber. When the patient has spontaneous breathing, they're not vented. They're not mechanically vented, not intubated. They're breathing on their own. So when they're spontaneously breathing, guys, the movement of the water will actually go up when the patient inhales. All right? When the patient exhales, the water level goes down. So that is the expected finding for the titling. And we are again talking about the water seal. This is normal. However, when the patient is vented or has an endotracheal tube, the movement of the water is the exact opposite. So I want you to pay attention here, because this might be the question in the NCLEX. So again, the movement of the water in the water seal chamber, the titling will be the exact opposite if the patient is placed in the mechanical ventilator. All right, that is way different. Okay, so when the patient breathes in, the water level goes down. When the patient exhales, the water level goes up. So quite the exact opposite. Now, if the patient's water seal chamber, again, we are still in this chamber right now. If there is a lack of titling, and let's talk about the immediate phase, just right after the chest tube has been inserted. So the lack of titling is going to be very significant at this point if there is no movement up and down of this chamber. That's not a good sign. Okay, during the acute phase, it could mean that there is an obstruction. Maybe there is going to be a clot in there, or there could be kinking of the tubing that's not allowing the drainage of the fluid or the blood coming from, or let's say not allowing the drainage of the air coming from the patient's chest. All right. So that's one reason why there is a lack of titling or no titling at all. Another reason for that is maybe because, yes, we'll talk about that more. So it could be that the lack of titling, there's no movement at all. It could be that there is now displacement of the catheter from the chest wall, from the intrapleural space. So that could be another reason. All right. All righty. So it would need to be repositioned correctly. So at this point in the acute phase, after the insertion, if there is no titling, yeah, it needs to be checked right away. It needs to be repositioned by the medical provider. We're not going to do the repositioning, guys. So another reason is that there is some leaking. All right. And where the leak is coming from, maybe there is some crack in the system itself. Maybe the container, the system itself is cracked, or let's say there is some connection in the tubing. Maybe there is loose connection from the chest tube itself into the tubing. Maybe there's no more tape in there securing the tubing. So those are the possible causes why there is lack of titling. And again, guys, don't get confused. We're still talking in the water seal, okay? Water seal when we are talking about titling, all right? Not here and not here. Focus on the water seal. Now, let's talk about further here. However, though, let's say, for example, when the patient is probably 4 days or 5 days after the insertion of the chest tube, and there is no more titling, there is decreasing titling. Again, this is probably a good news, right? It simply means maybe there is now resolution of the hemothorax or maybe resolution of the pneumothorax. That is a good finding if we are on the 3rd or 4th day or 5th day after the insertion. So this could mean that the patient's lung has re-expanded, all right? But again, you just don't rely on that one because things can happen, right? So please take note that when your patient is having the chest tube, there's gonna be a need to do daily chest X-rays, especially early in the morning. Daily chest X-ray, and this is to evaluate the position of the chest tube in the pleural space to see if there is dislodgement, and also to check if there is now re-expansion of the lung fields. Okay, so this is one way that we're going to tell, hey, our patient's getting better. At least they have some re-expansion at least 2 days after. So again, pay attention to the titling here. All right, so I hope that you're able to capture here about the titling. Again, that's going to be in the water seal chamber. Now we're going to talk about another observation that you need to do here. So for example, what are you going to do if there is a lack or no titling at all? During the acute phase, this is very critical, guys. If you'll observe that there is no movement of the water level in the water seal chamber, right here, if you're not going to see any rise and fall when they breathe, well, what you're going to do first, make sure that you assess the patient, okay? That's the first thing that you need to do. Check the respiratory status of the patient and ask them if they have any kind of chest pain. Check if they have any shortness of breath. All right, so take note of the respiratory pattern, the rate, the symmetry of the chest wall. This is very important. Make sure that you do this first if the patient's titling has stopped. Now, what you're going to do next is to inspect the tubing and also the connection. So look for those kinks, look for those clots, because these are the possible reasons why there is no more titling. And I'm talking about during the immediate phase post-insertion of the chest tube. So another that you're going to do here is to verify the chest tube position. And how are we going to do that? Well, of course, the chest X-ray that will be ordered as a follow-up right after the insertion of the chest tube. This is going to confirm to make sure that the placement of the chest tube has been well inserted into the pleural space, not advanced or not pulled out. Okay? So guys, here's the thing. If in case like you are the primary nurse and all of a sudden your patient starts pulling the chest tube, right? Because they're confused, yeah, that's a very risky situation here. So you're gonna notify the doctor about the risks that are involved here. Your patient probably is confused. So the patient might need an order for wrist restraints, right? In order to prevent them from tugging the chest tube. Now, another thing is that if in case there is suspicion that there is dislodgement of the chest tube, well, notify the medical provider right away. They might give you an order to do a follow-up chest x-ray. So this is to safeguard our treatment, especially in this situation. Now, what we're going to do next here is to check the drainage system. What are we going to look for? Look for those cracks and any signs of damage. Maybe the appliance, I'm talking about the system itself here, has been dropped. Oh boy, we don't want that. Or let's say it could probably have tilted over and it resulted to cracks. Definitely we need to change the appliance right away. So if in case there is now a accidental disconnection, what are we gonna do if there is accidental disconnection? Well, we are going to instruct the patient to exhale and also to cough, and this is going to facilitate that they're going to expel the air from the pleural space. All right, so again, you're going to instruct the patient to take deep breath and cough to allow the air to get expelled from the pleural space. And if the system is compromised, let's say for example there is a pulling of the tubes, then what you're going to do is to immerse the tube and in sterile water, and this is only temporary. Only temporary. Make sure that you dip into the sterile water, but make sure that somebody is being called out to make sure that they are assisting you. Make sure that there is replacement of the appliance right away. Now, another thing is if there is accidental removal of, let's say, the chest tube, we're going to dress the area with a sterile gauze, and we're not going to do that way too tight, because if it can be too tight, then it can also cause tension pneumothorax. We don't want that either. Now, if in case the tension pneumothorax occurs in this patient, what can we do to prevent here? Well, of course, check first for the manifestation. What are these? Well, potentially there could be a deviation of the trachea, or let's say the breath sounds of the patient is much more diminished, and maybe there is now distension of the neck veins, and there will be respiratory distress. So you're going to expect here a patient is really probably screaming in pain, or probably in air hunger, or it could be that there is now chest asymmetry because of the tension pneumothorax, like I've said earlier. And because of the compression of the heart and also the blood vessels, also decreasing the blood return to the heart, well, they're going to end up with the cyanosis, right? The cardiac output, the blood pressure is significantly reduced, so your patient's blood supply to the periphery and all the body organs will be decreased. This will require us to notify the medical provider immediately. Call them STAT. And it might require you to call the rapid response as well. All right? Rapid response team. Alert them right away. So this rapid response team is composed of a critical care nurse, the pharmacist, a phlebotomist, could be the house supervisor, could be the lift team guys, just in case they're going to have to check on the patient. If the patient would deteriorate way too fast, then definitely we need to address the situation. And what we're going to do here, part of the care just general. Well, of course, we're going to have to move it because I'm going to have to interrupt with that kind of presentation. We're going to move into the next observation, basically with the bubbling right now, which is another clue if there's any problem going on. So if there is no, if a known bubbling is observable, we're also going to look into the bubbling here in the water seal chamber. All right, we're not talking about the bubbling in the suction. No, not there. So when we are looking into the water seal chamber, and if there is a continuous bubbling, it definitely signals an air leak. Bad sign. This is a red flag. If there is a continuous bubbling, you definitely need to check the entire system for any leakage, okay? And we'll also need to check the connection, the chest tube itself, the insertion side, and the chest wall. So those are the things that you have to follow up, and also locate where the leak is. So where is it coming from? Is it the dressing or is it the insertion site? So you really have to be thorough to identify where the leak is coming from. Now, what you can do is to possibly clamp the chest tube momentarily. Again, this is an exception, guys. If there is continuous bubbling, applying the clamp momentarily to identify where the bubbling is acceptable. Okay, this will help you determine where exactly the leak is, and so you can resolve. It could be the dressing or the insertion site. It could be a loose connection in the tubing. So this is going to narrow down your investigation. Now, another is that you're going to have to check for the intermittent bubbling. So what is this? Well, this is expected. This is normal. The intermittent bubbling that you will see here is normal. We are talking about the water seal. And this simply means that there is now evacuation of the air from the pleural space, such as in the case of a pneumothorax. And it can also be observable when you're going to instruct the patient, for example, hey, I want you to take a deep breath this time. And so when you see the bubbling showing up in this chamber, that is normal. And if you're going to tell them, hey, I want you to do some coughing right now. Well, when you see the bubbles showing up in this chamber, that is normal. Okay, so that simply means that they are able to expel the air coming from the pleural space. Again, this is intermittent bubbling, guys, not continuous. All right. However, though, if there is now absence of bubbling, that is another thing. Okay, so please pay attention. Absence of bubbling can mean something. So what is that? It could be a blocked tubing, especially during the acute phase, right after the insertion. If there is no more bubbling at all, and it's a brand new chest tube, yeah, think about a possible blockage here. It could be a clot, or it could be a kink in the tubing itself. Now, if there is absence of bubbling, it could also mean that the system is failing, or maybe there is a malfunction. There could be a crack in there. However, though, if there is absence of bubbling, let's say maybe towards 4th day, 5th day, it could mean that the patient has a resolution to the pneumothorax as well. So again, you have to pay attention into your clinical assessment in the daily progression. Make sure that you're going to look into the nurse's notes, what the others have observed in the chamber, to see if there's any deterioration or, let's say, improvement in the patient's treatment plan. Okay, so again, absence of bubbling, it could mean good or it could be bad. It could be bad if it's happening early in the right after the insertion of the chest tube. Okay, all right, or it could be kinking. All right, but let's say 4 days after, 5 days, and let's say there is now probably the x-ray is showing that there is now re-expansion of the lungs. Well, that would really support, I would be comfortable that, hey, our patient is doing a lot better this time. So that could really mean that the patient probably would need removal of the chest tube this time. Okay. Now, what we're going to talk this time is about client education, and this is very important. So again, they need to be proactive themselves in order that they can also help themselves in having an early recovery from the hemo or the pneumothorax. So what are we going to do here? We're going to have them actively participate in the coughing and deep breathing, and also with the use of the incentive spirometer. Okay, what is the goal again with this? Again, we want them to have the maximum lung re-expansion. That is the goal. All right, so the deep breathing, the coughing, and the use of IS will help re-expand their lungs. Remember, I said something about the bubbling in the water seal when you ask them to deep breathe, or let's say to cough, and you will see the bubbles coming up in the water seal. Yeah, that's because they are expelling the air from the pleura into the water seal. That's kind of amazing, right? Now, we're also going to encourage hand hygiene, especially the patient, because we don't want them to have odo contamination, odo infection. We don't want that. So make sure that they observe proper hand hygiene. Also smoking cessation, because definitely with that, this can also promote healing. Same thing, they need to really follow up with a care provider to see if their healing has progressed, and make sure that they need to report to the medical provider if there is some sort of respiratory infection, maybe an upper respiratory tract infection, or could be fever. So they need to tell the doc about high temperature, maybe they're developing some form of infection, or let's say coughing, difficulty of breathing, or let's say sharp chest pain. So these are things that you need to incorporate in the teaching. Okay. Now another is that the sharp chest pain. I think we already said that one. Now, what are we going to do next? Especially when the patient is progressing. I'm talking about the patient's chest tube has worked well for them. So now we're going to get ready with a chest tube removal. So I want you to prepare yourself as well. So what are we going to do? Well, the procedure itself is painful. Imagine that catheter that is advanced into the pleural space. It passes into the chest wall. That is quite painful, guys. And so make sure that you're going to medicate your patient with a pain medication. Could be IV injection, could be morphine, could be fentanyl, could be dilaudid. At least do it 30 minutes before the removal. Make sure that you're going to coordinate with the medical provider when to do this exactly. And also you're going to assess or assist rather with the removal of the tube, and also during the suturing process. Okay. Now, very critical here during the removal is to instruct the patient to bear down, do the Valsalva's maneuver, and make sure they hold their breath during the removal. Okay, so what is the reason for that? This is to prevent the entry of atmospheric air into the pleural space. Okay, again, you need to instruct the patient to exhale and then bear down, or could instruct them to hold their breath during the removal. And this is again to prevent the entry of atmospheric air into the pleural space. Okay, this is very critical. Now, after that, you're going to have to apply an airtight sterile petroleum jelly gauze dressing. Okay, that's very important. And make sure that you're going to have to collaborate with a radiology department. Make sure that this is done right away to check proper placement, or let's say resolution of the pneumothorax or hydrothorax. So this is very important. Another is to check for any possible excessive wound drainage, or it could be any signs of infection, or it could be recurrence of the pneumothorax. So this is going to be your focus of care around this time. Okay. Now, to recap everything with the chest tube, because this is really probably gonna show up in the NCLEX exam. How are you going to safely manage your patient with a chest tube? Well, you have to really identify those risks. Okay, what are those risks possibly? Well, the presence of the bubbling, the presence of an air leak, and make sure where to look for these things. So if you are going to be concerned about the air leak, you definitely need to focus into the water seal. All right. Same thing with the bubbling. If you are worried about the bubbling, look into the water seal, not into the suction chamber, or let's say the drainage chamber. Look into the water seal. Like again, and so with the intermittent bubbling, this is going to be normal, right? If the patient is talking, or let's say when there is deep inspiration, or let's say when they're coughing, that is normal. However, continuous bubbling is a sign of an air leak. All right. So I really want you to go back into these concepts, because actually they're easy to capture and understand. You just need to refocus where to find those issues. That's the main thing here. So again, let's take a look into the chambers. This is where your focus is going to be at. As far as the titling, look into the water seal. Okay. Alrighty. So that actually ends the discussion today. I hope that you're able to comprehend these critical concepts. And please ask questions or put your comments in the comment section so we can address those in the next lecture. And I'm just going to let you know ahead of time that tomorrow we'll be talking about the acute respiratory distress syndrome. And yeah, I will see you again tomorrow. And I hope that you have a better day ahead.